Thank you for joining us this evening. My name is Selina Joffrey, and I'm the Director of Business and Policy at Asia Society Texas Center. Tonight's program relaunches the COVID-19 series, which we had started earlier this year in the spring. COVID-19 New Realities is a monthly series as we continue to bring you insights around the ongoing pandemic and its impact on the world. Our speaker this evening is Dr. Mark Boom, President and CEO of Houston Methodist. We launched our spring series with Dr. Boom in early April and are very grateful to have him back with us for the launch of this series. The Houston area saw record highs of COVID-19 infections this summer, and the Texas Medical Center had to come up with creative solutions in managing supplies, hospital capacity, and staff needs, while researchers continue to grapple with questions around reinfections, immunity, and the timeline for a vaccine. Tonight's discussion will be on the current state of the pandemic and what can be expected this fall. Our moderator is Marty Goosen. He's Vice Chairman of JP Morgan Private Bank and serves as Vice Chair of the Board of Directors at Asia Society Texas Center. Before we get started, I would like to share that Asia Society Texas Center is an educational institution promoting cultural exchange to celebrate diversity and foster a better understanding of our interconnected world. Because we believe in the importance of having access to diverse communities and perspectives, many of Asia Society's programs, like this one, are free. Please consider supporting our work through a tax-deductible gift by texting Asia Society TX to 243-725. We hope you enjoy the program. Thank you.
Thank you, Selina. It's great to be back in a second wave of our series on COVID-19. Perhaps at the beginning, we hoped we wouldn't need a second wave of the programs, but here we are. And we did start on April 2nd with Dr. Mark Boom, who started our first program, and he and I had, I thought, a very engaging conversation at a very different time. And I'm looking forward to getting Dr. Boom's view on where we are today and where we may be going from here. I'm going to cover, Mark, with you. And by the way, thank you once again for joining us. As Selina said, you're President and CEO of Houston Methodist. You have more degrees than most people can accumulate in a small family. From University of Texas, MD from Baylor College of Medicine, and an MBA from Wharton. And you've had numerous interviews across every platform that you can imagine, including CNN and Fox and others. So we are proud to have you with us this evening, and thank you for all you're doing in our community. I want to talk about three basic topics tonight, Mark. Where we are today, we're going to talk about that with a little bit of a historic background. I want to talk about the solutions, the medical solutions, things like therapeutics and vaccines. And I think that's a very important topic of the day. And then I'd like to spend the last few minutes on the future. But I do want to remind all our viewers that we want to have audience questions. And if you would please put them into the chat box on either your Facebook or YouTube, whatever platform you're using, we will get to those questions in the last 15 or so minutes of our program. Please put them there, and I will use the time at the end to direct those to Dr. Boom. So Mark, why don't we get going here about where we are today? Globally, nationally, statewide, and locally. Let me just give everybody some context. When you and I were speaking on April 2nd, it doesn't seem that long ago, right? It wasn't April Fool's Day, by the way. It might have felt like it at the time. But just over 5 months ago, there were 1 million global cases. Today, there are 27.7 million global cases. There are 1.9 million new cases just last week alone. That's a peak. At that time, there were 51,000 global deaths, many of them concentrated actually in China. Year to date, globally, there have been 900,000 global deaths. In the US, when we talked on April 2nd, There were 236,000 cases. Today, there are 6.4 million cases in the U.S., and there were 4,700 deaths at that time. There were 2,300 deaths at that time. And today, we have over 190,000 deaths in the U.S. Texas at the time had 4,700 cases. We now, sadly, have many, many more than that, over 600,000. At that time, there were 74, not deaths, those are cases, 74 deaths in Texas. Now there's over 13,000 deaths in Texas. And getting more close to home, at that time, there had only been 16 deaths in Houston, and now we have over 2,300. Now, obviously, those numbers are startling. Did you ever predict we were going to get to that level? I know we talked a lot about where could this go? Where is this going to go? And people had models and all sorts of statistical frameworks to predict what the future was. But as you look back now on those 5.5 months, what is your sense of how we got where we are today?
I guess, hindsight's always 2020. I wish we knew everything then that we know now. It's been one heck of a 5-month or so period for sure, as you've enumerated there very accurately. Put it in perspective, personally, our institution was about 8 days from peak at April 2nd. We peaked April 10th, and really our community peaked April 10th. And we came down and everybody sort of got comfortable. And next thing we knew, this thing really came back with a vengeance and got completely out of hand. And we're only now watching the dust settle a little bit from that. And, honestly, looking at plateau type numbers right now, certainly in our institution, that feel like the peak back in April in terms of the numbers that we're seeing, because we ended up having to be ready for so much more. It's what I think everybody was saying from the beginning. This is an explosive virus. When it has a spreading factor, what we call the R, as high as it does at its sort of native state, it can get out of control very, very quickly. And that's what you've seen. And unfortunately, there's still many projections out there to suggest, we've got a long way to go. Now, there's a lot of debate about that, and we can talk about some of that in detail. But, we have to bet that there may be a long way to go at this point in time.
Yes. And of course, one of the things we've learned in 2020 hindsight is that it's Texas versus some other state versus Houston versus some other city. There's no predictability necessarily on a very local level on how this has grown up, and how we at the time were really focused on New York, and we were really focused on a major center there and to a degree the West Coast. Of course, this came in mainly through Seattle and through Washington State, where the first cases were discovered, mainly through travel from overseas, from Asia. As you look at that, is just thinking about it specifically, as Texas, have we done a decent job in Texas in your own perspective in terms of somehow handling this better than maybe other states?
Well, it's a yes and no mixed answer. If you look at the Texas data, we actually have the second most number of cases in the country. So that's hardly something we wanted to see. Of course, we're a very high population state, so you would expect that we would be, among the top few. But if you went back to that time frame, we were probably barely even in the top 10. So in terms of number of cases, we have had quite an outbreak here in Texas, and really the biggest outbreak, along with Arizona and Florida, that was happening over the course of the summer. In terms of deaths, it's very interesting, because if you look at a state like New York, which had that big early surge, their death rate on a pure case fatality rate, so number of deaths over the number of cases that we know about, so people who are sick enough to really come to attention, was significantly higher than what we have experienced in Texas. In fact, we're one of the lowest states. We're somewhere, under 2% or so as a state. Now, some of that's because we've tested more now than we were able to test back then, so our denominator's bigger. Some of that is we seem to have had, for whatever reasons we don't fully understand, some milder populations, some maybe some age distribution. I think where we have not, done as well, and hence the number of infections, really probably was less about what Texas was doing and more about kind of what was happening in collective psyche, I think, in May. I mean, I alluded to this before. There was this point in late May where we all said, hey, it's summer, breathe a sigh of relief. The worst seems to be over. New York's really gotten this in control. Nowhere else seemed to be as bad as we thought it would be. And, we really let our guard down. And then the other thing that, really went wrong, I think, nationally, is that we allowed politics, and of course there was an inevitability to that, but we linked arms during the first wave, this first surge. Most everybody was on similar pages. We did what we felt like we had to do at the time, and then the discussions began, and two parties staked out their positions, and you saw a lot of politics creep into this, and so some really honestly, suspect discussion, communication, decision-making, particularly around masks, which, by then the science was really becoming clear that we needed to wear masks. And yet we were staking out political positions to say, don't wear masks, and had to get through, several months really of debate as a society nationally to say, do we do this or not? And thankfully we finally have mostly gotten over that hump, and it's no coincidence. And we'll talk about that we're doing much better. It is because of this.
Of course, one of the biggest topics at that time, if I remember correctly, was the question around testing, and the question whether we were getting enough tests. I remember you were talking about you weren't able to get the necessary chemicals to actually complete the test. You could take the sample, but you couldn't actually test it because you didn't get the ingredients that you needed. That U.S. through since March 1st has tested 44 million people. In Texas, we've tested, I think, almost 6 million people. And across the country now, it seems like we're testing about 2 million people a week. A lot of people suggest that's still not enough. Yet I hear a lot of concerns about, I got a false positive, or I got a negative. And by the way, what good's a negative test anyways? You're only negative on the moment of the test. So what has been your thoughts as you look backwards on the importance of testing and how we handled that?
Well, testing is very important. We societally bungled that back in the January, February timeframe. There's no question about that. Many institutions like ours had that up and running, were able to do that quickly. And then, as we talked about in April, the problem was you couldn't get these reagents and the DNA or the nucleic acid extraction kits and things. Those issues have largely resolved themselves. You still can't get all of the equipment you want. Nobody could do unlimited numbers of tests because they're not going to get, the access to everything they need. But the reality is, in many communities, ours included, we're not using all the testing capacity we have today. At Houston Methodist, for instance, we can do over 3,000 tests a day, actually more like 3,500. At peak, we were doing almost that. But now, a big busy day is 1,200 because there's much less prevalence in the community. There was a plan that came out in the spring. They called it the 1-3-30 plan. And the idea was within a month to get to 1 million a day and et cetera, et cetera. And then ultimately by end of the year, we're supposed to be at 30 million, I believe, capacity. We're not on track to do that. Frankly, with the PCR test, which still requires somebody, sticking a swab all the way in the back of your nasopharynx, many of us have now had that done. I've had that done. It's not the most pleasant test. It's not horrible, but it's not the most pleasant test. It's certainly not one you want to get done daily if you can help it. We still don't have adequate supplies or even quality of rapid testing, because that could be transformational. If you could envision a rapid, cheap test that we could do on saliva, and you literally in a college campus or, across schools or in a place of business or hospital could literally have people, for a couple bucks a day testing themselves daily, you could really change the paradigm a lot. So there's still a potential for testing to kick in and be, very helpful going forward.
Particularly in this particular virus because of the asymptomatic problems here.
Exactly.
Unless you know you have it, you don't know you're infectious. And how else are you going to find that out until you actually potentially infect someone? One of the things we also talked a little bit about in those earlier calls were about contact tracing. And that's proven to be more challenging than testing, I think. Is that correct? And I know that Harris County was building up a whole contact tracing capability. Where does that stand today?
Yeah, there's no question that's been frustrating and has been slow to come about. There was a point when it became, frankly, almost moot, because there's no community when it's having, 2,500 cases in the community a day come through that's going to be able to contact trace. That's an army of contact tracers. So when we really surged back again in May, then June, at a point where we really had not put in place the contact tracing to try and keep it down, there was a point where, I think they almost had to throw their hands up and say, it's kind of pointless. We're re-entering now a phase where contact tracing should be critically important. And I don't believe we're all the way where we need to be from a higher. We're in better position as a community, but I do think when we look back at some of the, the opportunities for next time, or later in this pandemic, public health infrastructure is going to be one of those massive things we look at across the country. Whether you're talking the CDC, whether you're talking state, county level, city level, we are under-resourced, under-personnel, et cetera. And we're going to have to really rethink that as a society if we want to be ready for the next time around.
You referred to this point a little earlier, the politics of opening or not opening. So a big deal happening later this month in New York, they're finally going to allow indoor dining. Mm-hmm. Now, we've had indoor dining in Houston at 25% and now 50% for quite a long time. In fact, on May 21st, the governor opened the bars to 25% capacity. And he admitted later on that maybe that was too soon because then we had Memorial Day weekend and all like that. People have called for a national strategy, but actually the local strategies have had very different outcomes. As you suggested, New York's had nearly 3 times as many deaths as we had, and they've been closed since early March. And we opened 3 to 4 months ago. Do you have a sense of whether or not opening and closing was as big a political issue as it should have been? Because it really was a major conversation.
Well, and it still is a big political issue. I mean, we have to, I think, acknowledge that and face that both parties have decided to take a stake in that, and at least until the presidential election or the election in general, I suspect we're going to see people kind of sticking in their camps there around that. And like most things in life, the right answer is somewhere in between. You can't go, pedal to the metal, don't look at any of the data, never stop to pause, never stop to think about it and reopen things. And on the flip side, it's a very false choice to say we need to close everything down. And I think we've shown now, coming through this second surge, there are many horrible things about the second surge, of course. One of the things, though, that's positive to me is we really clearly showed what will control this. And short of a shutdown, masks will control this. And some of the attendant behaviors that go with wearing a mask, but masks do control this. We were really spinning out of control in the greater Houston area if you look at late June and right into the beginning of July. And with those masking orders, and now, and I like your Houston Astros mask there, with those now, we've seen significant control. So, if there's one message I'd want everybody to walk out of tonight hearing, it's that we need to keep masks as mandatory as possible for as long as possible. And we societally have to have the patience and the vigilance and the diligence and really the social contract to say we will continue wearing them, because I think we can actually do many things to advance society with wearing masks if we do this correctly.
Well, certainly countries across Asia realize that masks, which are very common there, are one of the positives that I think kept their caseload. And we just need to be more diligent. You say, I'm going to take this off because it's too hot and it fogs up my glasses. Let's talk about the other thing we were all worried about in April, which was how is our medical system going to be able to deal with the new cases, the severe cases? Do we have enough ventilators? Did we have enough PPE? And of course, in those early days, we weren't prepared. But where we sit today, I look at the TMC, the Texas Medical Center website, and it appears to me as though, at least here in Houston in our neighborhood, we've got pretty good control over what's going on in the medical center and in our institutions like Houston Methodist.
Yeah, I think collectively we've fared pretty well, not without challenge for sure, and particularly at the staff level, this has been rough. It's been a long 6-month journey. Thankfully, over the last 4 to 6 weeks, we've really started to be able to spell some people and give them a little bit of a break. And psychologically, it's just so different to be one of those frontline individuals on the way up than it is on the way down. Even if you're at the same number of patients, it's just a different scenario. And I will say particularly hard for staff to have observed sort of honestly some lackadaisical behaviors, some dissension around some of the things everybody knew worked very effectively at a time when they were watching so many people be so incredibly ill, and they were literally pulling out their hair trying to keep up with what was happening. So that first surge, to put it in perspective, we peaked, and I'll use our numbers just to give perspective, but you'd see pretty much consistent numbers, based on size and market share across the TMC institutions. We peaked of known positives right at about 210 or so patients in-house. And to put that in perspective, in a normal flu season, we'll see at peak about 100 patients in our hospital. Excuse me. In 2017 to 18, we had about 196 peak in flu. It was a bad flu season, and we'll come back to that issue. We then got up to 750 patients in our hospital at any given time at the end of June, which was one heck of a different situation. That most definitely stretched capacity. We managed through it, but it was most definitely a big challenge.
Yeah, and I think the question we have to, number one, ask ourselves, have we respected sufficiently the work that everybody in your institution and all the institutions across the country have done? Because this has been without break. Flu seasons come and go, generally speaking. Isn't that accurate?
Oh, it's a 6-week period where it really spikes for us. So when I talk about those surges, that happens over the course of end of December, mid-December to mid-February at the latest.
And so here we're 6 months into this with no particular end in sight. And your staff are under that same pressure day after day after day. So on behalf of everybody in our community, I need to respect them and thank them. And I hope you'll pass that along to them.
Thank you. And the good news is that, and this was a major learning the first time around. So, as you mentioned, societally, PPE supply chain wasn't in place. We didn't understand how the virus would act, et cetera. So to be cautious, everybody shut down their elective procedures and cut back on a lot of normal healthcare. We did that, as did our colleagues across the Texas Medical Center, well in advance of the governor's order to do that. But on the back end of that, as we kind of let the dust settle, we looked back at that and said, people missed needed care. People suffered needlessly. There was people afraid of going to emergency rooms, and we saw heart attack out of hospital deaths go up. We saw stroke numbers go down, which made no biological sense. We've seen people delay screening tests, et cetera, et cetera. And so we really set about for that second surge, which frankly, we thought would be coming right around now. We didn't think it'd be coming in mid-June. But in early May, we set out the guidance that said we will operate as normally as possible for non-COVID throughout whatever a second surge comes. And it was really only a couple-week period in the midst of July where we had to back off of a little bit of normally planned inpatient surgeries to free up space to care for COVID patients. So, the vast majority of patients who needed care and sought care, that's an important distinction because some people were still staying away out of fear. We're able to get that care. And that's something I'm really proud of, and something I think that will have minimized some of the non-COVID harm happening in the second surge this summer that happened, no question, in that first surge. And really right now, our message is, look, we're back down to kind of levels that we can sustain and manage. So as a community, we do the things to stay and keep this in control. But from a healthcare perspective, people need to get back to all of their routine care. I have talked to people who, are getting their mammograms now and who are, unfortunately, some percentage of those are positive. When you don't get those as planned, you delay necessary care. Colonoscopies are another great example. And then, of course, many other surgical procedures and more advanced.
And we've all heard the tragic stories of people being deathly ill in the hospital with something completely unrelated to COVID, and their families unable to visit them. People passing away in various hospitals, again, with their family not at their side because you're having to restrict the visitors into your institutions. And that's a sad unintended consequence of what we're going through.
Yeah, it really is a very hard thing. It's hard on, obviously, first and foremost, the staff, the patients and their family members, but also the staff who, see that and have to oftentimes be almost surrogates for that. And there's been a lot of, very heartbreaking but touching, beautiful stories about how they have stepped up and done that. But nonetheless, it's been very difficult. And of course, as we lose loved ones, also, we've all lost that moment of funeral when we stop and pause and acknowledge someone's life and get together and grieve together. I mean, there's so many things we've lost as a result of COVID, that we obviously all want to get back as soon as possible. And that would be one of them.
Well, one of the things we are getting back, but again, not with large crowds, is football tonight. So we're up against football tonight, you and I. So
and basketball, I know.
And basketball too, yes, and whatever. So let's move on to the medical solutions. First, let's talk about therapeutics, because this was, in the early going, there was a lot of talk about therapeutics. Of course, the president was touting hydroxychloroquine. We've heard about other drugs. The FDA established an emergency program called the Coronavirus Treatment Acceleration Program, or CTAP, or whatever you might have called it. And evidently, there are hundreds of drugs under development and different trials. But only 5 treatments have been given emergency use and 0 have been given formal approval from the FDA, if I understand the figures. What's going on in terms of therapeutics? I know you've been very involved at Methodist in convalescent plasma. What other things are actually going on there? Are there promising therapeutics that are being developed today?
As you said, there's countless angles that people are trying to understand. And, you can look at agents that are against the virus specifically, like an antiviral. You can look at other agents that may arm the body or encourage the body to kind of fight that. And you can look at other agents that are there really to modulate the body's response, because oftentimes the people who do really severely, as much of the damage ends up from their body's sort of overactive response, what was oftentimes being referred to as, the cytokine storm. That science around that's evolving as well, but nonetheless, the kind of immunological system goes haywire, and we need to manage that. And some areas of that have been quite promising. Some areas of that have been somewhat disappointing, honestly, as we look at that. And none have been, the desired sort of silver bullet that would really change the paradigm. And if we look at a couple of those, one of the early successes was remdesivir.
Yep.
So remdesivir is a drug that's been developed in the past, actually attempted for Ebola and some other viruses, never really caught on because it never really worked, but it was on the shelf. It had been tested, so it had a bunch of safety data behind it. So it could be utilized pretty quickly. And thankfully, in a randomized controlled trial, it showed some pretty strong signal. The specific statistically proven piece was that it shortened length of stay, so that it actually enhanced or accelerated recovery. But it did not have statistically significant improvement in mortality, although there was a strong signal. In other words, there was a mortality decrease, but it didn't meet the statistical thresholds to say yes. With that data, the FDA issued an EUA, and we all began using it. And in fact, it was all being controlled through the government, distributed through the government. The manufacturer donated it to the government. And then around mid to end of June, it transitioned into something that the company sells. It's still in undersupply, particularly as we were surging there. So we had to have strategies to allocate it to, through a protocol, basically figure out who could get it, who couldn't get it. A modest success factor, but a success factor nonetheless. There's another drug called favipiravir, which is an oral drug that operates at that same step, also an antiviral. We are studying that. Many people around the world are studying. We're part of the trials. We don't have any data yet, so I don't know yet if it works. But if it, because it's, it's not a Me Too drug, but it's in that same family as remdesivir. If it were to work, it's oral, which obviously could be more transformative than remdesivir because we could get it to people early. It could be the Tamiflu of COVID, which would be nice. Tamiflu is a good drug. It's not a great drug, right? It tends to, it can be used in a variety of ways. In a family, it can prevent somebody else from getting infected. It shortens the duration of flu symptoms. It lessens the severity and the likelihood that one gets critically ill, but it is hardly a panacea. It doesn't, work perfectly and has to be given early. And I think at best, probably, at least hypothetically, something like favipiravir would look like that. Probably the biggest success factor is a tried and true old drug, and that's corticosteroids, or dexamethasone is the first one that was studied. It came out of Oxford in a very well done randomized controlled trial. This is interesting because when we first started, in fact, when we were talking in April, it was probably only just starting to shift, which is all the news coming out of China, all the news coming out of Italy was don't give steroids. It makes people much worse. And, and so they weren't being used much, but this trial was done and it showed that was mostly wrong. And I say mostly because what it showed was later in disease, when the immune system's getting out of whack, it's highly effective at actually decreasing mortality statistically significantly, but it's probably detrimental early in disease. And it makes intuitive sense because when your body needs to rev up and do an immune response early, you don't want an anti-inflammatory or basically something that's going to push down the immune system like a steroid on board. But later when the immune system is a little haywire, you do want that on board. And so that's been a big success as well.
How about your experiments with convalescent plasma?
Well, we're very bullish on convalescent plasma, but the jury's still out. So we were the first in the country right about the time of our talk. We were the first in the country to use it, followed closely by Mount Sinai in New York. Nationally, they set about doing a randomized controlled trial, but there also was an emergency use authorization, really with the idea being that here's a tried and true 100-plus-year-old therapy. We give plasma all the time as essentially for clotting reasons. So we know we can pull plasma and give plasma safely. We quickly were able in the studies to show that it was safe. And then the question was, does it work or not? But we've used this in, probably a dozen diseases over the last 100 years. So at the end of the day, we still don't know the answer to that, but there's some pretty strong evidence. So if you look at, I'll take our trial, we did 316 patients in our trial. If you look at all comers, you see a signal for some mortality decrease, but it is far from statistically significant. So we can't really draw a conclusion from that. Now that's in a case-matched series. So in other words, you take the people who gave it to, and then you find a group of patients who didn't get it, who have all the characteristics you can essentially think of matched as best as possible. Those studies tend to usually overestimate effect, so we know they're not perfect. If you drill down and you actually say, if it's in the first 72 hours and you give high titer, in other words, a large amount of antibody that's in one of the convalescent plasmas that's high, we saw a very significant decrease in mortality. And it makes logical sense from a medical perspective because high titer, right? So there's a dose response curve. And earlier on, when people don't have the antibodies yet, and not later on when they've probably already made their antibodies. And if they're really sick, their antibodies aren't doing it. So adding a few more antibodies to the mix may not work. So the Mayo Clinics led a multi-site trial, which showed essentially the same information, which is early, higher titer, dose response curve. And a small study out of Sinai as well said the same thing. Now, unfortunately, this was one of those things that got politicized. There was a little bit of a turf battle between the NIH and the FDA over should it happen, should it not happen. And then the politicians got involved. And then, of course, you had both sides, yelling at each other about the politics. And you'll see medical science still disagree on it. Our view is that an EUA to use this now, essentially compassionately in many cases while you're gathering data, is very reasonable given the limited number of things we have. Given the fact that it's not mutually exclusive with a randomized control, given the fact that it's a 100-year history, and given the fact that it's very much a stepping stone to one of the other potentially promising therapies, which is monoclonal antibodies. So the convalescent plasma is giving people that liquid portion of blood that contains antibodies, and we're measuring those titers. Monoclonal antibodies would be a biotech company basically making in vats, essentially, a large quantity of those very same antibodies and giving them. And there are randomized controlled trials. We're in them right now, and 2 of them happening both on an inpatient and very, very soon on an outpatient basis as to whether those would be effective as well. So again, we believe in the right scenarios, they're effective, far from a panacea, far from a silver bullet, but one of the tools that we do believe is effective.
So, Dr. Bohm, let's move on to vaccines, because I think this is really going to be an important conversation. Evidently, there are over 130 different vaccines in various stages of development being tested on animals and on humans. Russia's already said they have one, by the way, which I'm not sure I would take. According to statistics I saw, 25 different vaccines are now in phase 1, 14 in phase 2, 9 are in phase 3. 3 are approved for very early use, but none are obviously fully approved by the FDA at this stage for full use. We have 5 companies that we know are actively involved in this process: AstraZeneca, Moderna, Pfizer, Novavax, J&J, and Biotech SE. I guess that's 6 companies. But in any case, there are a number of companies that are doing this across the country. An interesting recent development is AstraZeneca suspended their trial on a UK patient who came down with a untimely complication. I understand they've been released from the hospital either yesterday or today, but this is why trials take so long, because when you're trying to, I guess they've tested 50,000 people or something, this is going to happen, right? And this is going to delay the possible release of a truly effective and safe vaccine. How does that work?
Yeah, so each of those vaccines that you mentioned, and there's really, as you said, 5 or 6 sort of front runners right now. The Oxford AstraZeneca was one of those very clearly, and I think still is. In fact, they had one of the earliest timelines predicted of all of the vaccines, but now for the second time during their trial, have put a pause on, which may be very brief. We don't know yet. So all of those trials have what's called an independent data safety monitoring board. So this group of professionals can look at the data and then ultimately look at the data in unblinded fashion, but they're completely independent. They're not able to, to crosstalk, and they're there really to oversee the safety of the subject population. They also can end a trial early if there's so much, strong signal that it's a slam dunk. But usually their biggest impact is this kind of thing. It's not unusual for a trial to get stopped. When you talk tens of thousands of people, some of those people, whether it has to do with the vaccine or not, are going to get certain illnesses. And in this case, the patient had what's called transverse myelitis, which think of it as basically an inflammation or infection across a level of their spinal cord, which I don't know anything about that particular patient, but in theory, at least would result in paralysis or partial paralysis below, or sensory loss or other things below that level. Oftentimes reversible. It is something we see. We see it from infectious agents and others. We see it or something similar to it in multiple sclerosis and other things. It's totally unknown whether that has anything to do with the vaccine. It is a patient in the vaccine arm. So that's what that board has to start taking a look at in trying to figure that out. The incidence of that is far lower than the 1 in 30,000 or whatever have gotten it. In other words, much more rare than that. But of course, you throw enough numbers together, those diseases will happen. So this is not unusual. It happens during trials. None of us have an idea yet as to whether, that'll pan out to be a real problem or not. But it is why trials take a long time and why they slow down and why we must follow normal protocol and do the full phase 3 trials to understand these vaccines, especially given that we're going to give them, ultimately to, millions and millions or hundreds of millions of people for each vaccine.
So I'm going to direct you one of the audience questions, which I think Eddie asked, why is it so slow to test these vaccines? If you need 30,000, 50,000 participants, in his view, you could probably find 1 million participants in these trials if you actually just went out and asked them. Do you have to do it 10,000 at a time? Can't you do it 100,000 at a time or 1 million at a time? How does that work?
Well, they're always balancing. Obviously, that's a great question. They're balancing a lot, right? They want to get enough numbers that they can get an answer, and do it feasibly, do it quickly enough. Obviously, it takes an army to be able to do that. And compared to, as hard as vaccinating 1 million people will be, that's no easy feat when we start talking about, 200 million people across the US. If you were to get, 2/3 of the population vaccinated or something like that, to then do all of the monitoring. Because remember, these patients are not just, hey, get a vaccine and we'll see in 2 months and see what happens. They're being constantly monitored, blood tested, and interviewed. And it's really a very thorough process. So there's a balancing act with that. Typically, this is about the size for most vaccine trials that we will see. The reason it takes a while, so most of these vaccines take 2 doses, 4 to 6 or so weeks apart. So right there, you've got a spread. And then really only after that time are you going to start counting who's getting sick, who's not getting sick. And you need enough time for enough people to get sick that you actually can get a numerical difference between the 2 groups. Obviously, the higher the prevalence of disease, the quicker that will happen. The best time to ever do a vaccine study in Houston would have been, get people vaccinated on their first shot, beginning of May, their second shot, mid-June, and you'd have had the perfect 2-month time frame there. But that's not how it works, and most of them were really vaccinating the first time in July. So most of the studies, and if you talk to listen to the companies in their reports, really end of October, absolute earliest that they might have some data coming out. And I think most likely it's going to be a little longer. Actually, some of the success in having the virus start coming down in the US is only going to slow that down. All of that being said, with a little asterisk next to AstraZeneca right now, a lot of good news has come out. These vaccines mount immune response. The amount of antibody that we're seeing in those patients' serum for a couple of the vaccine candidates is 3 to 5 to 8 or even times higher what you would see with convalescent plasma. The virus looks to neutralize, the antibody looks to neutralize, the antibodies that are formed look to neutralize the virus. When they do monkey studies, a couple of these vaccines actually prevent infection. So a vaccine can prevent infection and a vaccine can prevent disease. Those are not the same thing, right? You can get a vaccine that may not prevent infection, but really minimizes disease. So you still get it, but your symptoms are far less. The flu shot works like that. For many people, it prevents them from getting it. For those who do get it, it tends to be less severe. A couple of these candidates, it looks like it flat out prevents the monkeys at all from getting the illness, which is, if you want to shut it down, what you really need. So there's a lot of good data out there. And also they mount a cellular immune response in addition to an antibody immune response. So we're very encouraged by the data we see, but realistically, we're talking, I think, best case, end of this year for a small number of people starting to get vaccinated, but the real bulk of vaccination or vaccine availability and vaccination activity would be first and second quarter of next year, I think, realistically.
Of course, the logistics of this are amazing. So what you're basically saying, I think 4 of the 5 of the vaccines are 2-dose vaccines, right? I think
yes, correct.
I think the J&J, is it the J&J?
I think that's the one, right?
Is a single dose. But that means if you're gonna vaccinate 250 million people in the United States, just as an example, you're gonna need 500 doses.
Right.
It means you need 500 vials, which means you need to move it around. I read an article today said it was going to take 8,000 jumbo jets to deliver the hundreds of millions of vaccine doses around the world. Who knows where that number came from? Another statistician, perhaps. But the question is the logistics of building it up. While there's going to be a lot of money after the government's, the president has certainly promised all the money in the world. Just the logistics of delivering hundreds of millions of doses, not just in the United States, but in India and China and other countries around the world. It's going to be an amazing feat, I would guess.
Herculean. It really is a very challenging task. And then, we can't underestimate, that we need to get people to take this, right? So we already see that many of the studies out there suggest that about maybe half of people say they'll get it, and part of the other half say,
you talked
let
about
Mikey do it first, and then the last bit are like, hell no, I'll never do that. So it's hardly, even if we get the logistics solved, something that, will automatically get us to full-fledged herd immunity.
Yeah, you talked the last time we spoke, Dr. Bohm, about the no vaccine group out there. And you said that that's something like 30% of the US population. So if that's true, and there are 30% of the people out there that will not get a vaccine of any sort, measles, mumps, whatever, that would limit the herd immunity value of having everybody vaccinated against the disease, wouldn't it?
No question. And, herd immunity is an interesting topic. I mean, talk about a hot topic right now, because you'll see a lot in the press, you'll see a lot of scientific debate about, what is that number? We know that for something incredibly infectious like measles, you need 93, 94, 95% of people vaccinated to stop measles. Hence, people need to get their measles shots, which is incredibly safe. For something like this, when the R naught, or the spreading factor without us doing anything is running about 3, typically we've looked at 60 to 70% or so is what we need as that herd immunity threshold. But there's a lot out there right now being discussed about perhaps it's lower, which could be good news. Some mathematical models that say, hey, yeah, that makes sense if every person, if you consider each person sort of a point, across the country, if every point was the same, but every person's of course not the same. Some are more susceptible, some are less susceptible, some, et cetera. Some populations may have different characteristics, older in New York, for instance, on average than in a Houston, or some dynamics like that. There's also discussion about whether we have perhaps in some parts of the population some partial immunity. We know, the coronavirus that is out there now, COVID, is the same type of coronavirus as a couple of the seasonal coronaviruses. So it's certainly not implausible to think there could be some cross-reactivity. And there are a number of decent studies starting to suggest that there may be. And, one of the things that has befuddled us clinically since the beginning is, why do we have some people, and more as we learned how many asymptomatic people there were, why do you have some people who it's like, well, that was no big deal. It was nothing, compared to even the flu. And then we have other people. I mean, I've had people, some of my clinicians describe watching, healthy people melt away before their eyes in hours, and how we have that difference there. And clearly, there's probably genetic differences in populations. We've seen clusters and families that certainly one plausible explanation is some genetic susceptibility. But there's also that question of perhaps that wide variability is that we actually, some of us have some innate immunity. And we've seen that before. So if you go back to the Spanish flu epidemic in 1918, 1919, it was almost the inverse of this. It was killing all the 20-year-olds. It was horrible, right? All the people who were there melting away. And of course, they didn't have ICU care and all the things we do today, but it was killing 20-something-year-olds. And later, when they took a look at it, really the theory around that was that the older people had seen a more similar flu during their lifetime and had some partial immunity. And those young people, who were 18 years old, 20 years old, had never seen it. So we may have that dynamic going here. Nobody knows that for sure, but those are some encouraging things out there, because if that were true, it will decrease that hurdle that we need to get in terms of herd immunity.
So I want to get to the future, and a question that Ray asked, again, going out to the audience, is a question that I was going to ask. He puts it very eloquently: will we ever be post-pandemic?
Boy, I wish I knew that. I'd like the crystal ball. I would have liked the crystal ball back in April. It's very uncertain. There's a lot of good scientific minds who believe that this coronavirus will probably be with us for a long period of time, but not nearly in the way it is now. I mean, we will develop some herd immunity. We do appear to have a reasonable duration of lasting immunity. When I say reasonable duration, most people probably don't believe this is, hey, give people your childhood immunizations and they're good for the rest of their lives, but a couple of years of immunity. So it may be something that we're kind of living with constantly, but we're boostering, we're taking new vaccines, et cetera. Thankfully, we've not seen a very meaningful, and I'll knock wood while I say that, mutation in this. And actually, this virus has not been mutating kind of as wildly as the flu does, because the flu is constantly changing, and hence we always see something different every year, and oftentimes don't even quite get it right from an immunization standpoint. We've seen probably a mutation that increased the transmissibility of the virus, and it looks like the strain that we have here in Houston is essentially all that strain, but we've not seen anything that seems to change its lethality for patients, which is good news. Now, that doesn't mean that could never happen. If I had to bet, I think we're going to live with some form of this coronavirus, but I think also we have to look at the fact and the cold hard reality that for the third time in 20 years, we've seen a coronavirus jump from animals into man. And we just, had different versions of them before, both SARS and MERS, for different reasons, or for similar reasons, but different reasons than this, didn't catch hold as much. Probably the most significant of which was there didn't seem to be this asymptomatic mix. It was, if you had SARS, you were most likely sick as anything. Same thing with MERS. Very high mortality rates, especially with MERS. And so patients were identified quickly. You could contact trace, you could isolate, you could do those things much more easily than when you have a virus like this, where so many people are, barely knowing they have it at one end of the spectrum.
So we're getting dangerously close to the end of our time, and we have a large number of audience questions. I'm just going to ask you a simple one. Should I get my flu shot?
Please get your flu shot. Yes.
Should everybody get their flu shot?
Never more important than this year than to get your flu shot. If we look at the adult population in the US, less than half typically get their flu shot. And we lose the ability to prevent probably several, 10, 20, 30, 40,000 deaths. It's a statistical analysis from the CDC. They don't actually have a counting process. So if anything, those numbers may even be less accurate than the COVID numbers we see. But the last thing you want to do, let me say, from a selfish personal reason, we saw about a dozen or so, 12 or 15 patients in the tail end of last flu season have COVID and the flu. 60% mortality, bad combo. So from a personal selfish perspective, don't put yourself in a position to get both. From a societal perspective, last thing we need is 100 to 200 patients at Methodist, for instance, loading up on flu and then having the hundreds from COVID on top of that when it's preventable. And we can't prevent everyone, but we can largely prevent. Go get them now. The optimal times usually kind of latter half of September, probably, to get it. They're everywhere, and everybody's doing a big push this year. So please get your flu shot.
Yes. As we got into the crisis, Dr. Fauci said, we may never shake hands again. Maybe we shouldn't shake hands again. We've learned that masks can be helpful. People in Asia, we know, had much lower incidence of COVID because of masks. Are there some societal changes that we have to get comfortable with so that we can get back to whatever normal is going to be in the future? And I mean, I think I know your answer to this question, but I'd love to hear how you think about that.
Well, first off, and this was what I alluded to at the beginning, unfortunately, the very same people who were damn the torpedoes, full speed ahead at the whole time were also sitting there saying, and hell no, don't do a mask while you're at it. And it was the most sort of intellectually, diametrically opposed views or illogical views, because masks are a means to being able to do that. The more we all collectively mask and do the things we need to do like that, the more we get to actually, short of masks, live relatively normally. And I don't like wearing a mask either. My surgeons kind of laugh at me. I'm an internist because they're like, we wear these all day long. What are you people are whining about? But the reality is you don't need to wear it in your home. You don't need to wear it in your car. You don't need to wear it when you're outside exercising or walking around, keeping away from people. But when you're with other people that you're not, sharing life with, like your household, you should be wearing a mask. And if we can go back in a high prevalence environment where our employees are taking care of sick people and we keep them well wearing masks, we know you can do it in a school. You can do it in a church. You can do it in a place of business. And in fact, Greater Houston and Texas actually were, much more permissive from a business perspective from day one. I'm not talking after May 1st. I'm talking throughout the first time than many states. We had a huge essential business group, and those people weren't getting sick because they went to work with the right protections in place. So we can do that. And it's really the cost of getting life back to normal. When you ask other things, handshakes are going to be an interesting thing. I still find myself kind of, almost doing that sometimes. I know we all do. It's so embedded societally. Personally, it is one of the most illogical things we do societally. If you think about the flu, if you think about other infectious diseases, maybe the elbow bump or some other things will supplant that. I mean, I think we need something. And maybe we'll go back to it. I don't know, but things will change. The last thing I'll say, and that's the good news about flu, is we saw it diminish significantly this summer in the Southern Hemisphere. And that's because it's much less spreadable than COVID. So many of the things we're doing for COVID will also help prevent the flu. But again, with an opportunity to vaccinate, we should not, miss that opportunity to really keep that in even better control.
Dr. Boom, you mentioned that three, if you will, viruses in the last 20 years, came out of basically animal to human transmission. And we've been debating the value of the WHO, the value of organizations like the CDC. The United States is theoretically pulling out of the WHO. It sounds to me like this is an environment where we should be somehow taking over the WHO because the lack of information coming through the WHO, and of course it's been very politicized as well, might well, if we'd gotten to it earlier, might have well saved hundreds of thousands of lives. How do we get our politicians globally and nationally focused on ensuring that we don't have a fourth pandemic in the next 5 to 10 years?
Well, you've hit upon it. We need to invest in surveillance. We need to invest in the public health infrastructure to do that. And if, the CDC has been honestly starved for quite some time. I think we've seen a lot of the result of that. It was the poster child of the world, the envy of the world in terms of its ability to attack and focus on disease. And it has, not comported itself as well, I think, as it could have this time. And I think a large part of that has to do with resourcing, funding, and frankly, some politics now clearly that have gotten in the mix as well. And I'm not pointing at a party. I point at both. This is politics really across both sides of the aisle, and something that shouldn't be political at all. Okay, if the WHO isn't working, the answer is let's go fix it and make it work. We need a worldwide entity that is focused on infectious disease and the health of the global population. Because if this showed us anything, it's how global we are in this day and age. And so we need to focus on that. So significant resourcing of those efforts, of public health efforts. There's a lot that could be done. So, for example, we've known for a long time, and we had our couple big time shots across the bow that coronaviruses could jump into man from animals. So why weren't we investing, prodigious sums of money in supporting research, both in the kind of public domain, the NIH realm, but also probably working with pharma and others who, frankly, in a purely capitalistic model, I wouldn't make that decision if I was running big pharma either, to go bet on the come that there would be some need for a broad-based, widespread universal coronavirus vaccine. So that to me is where societal government comes in and says, you know what, but if the threat's there, we should be funding research on how do we find a universal coronavirus vaccine. And so the next time one comes out, you've at least got some cross-reactivity you can get people, and maybe even better. Same thing with drugs. We got a little bit lucky that remdesivir was on the shelf, but we haven't really gotten lucky with much else that was on the shelf, at least so far. We should be looking at, okay, where are the potential threats? Not all will be foreseeable, but those that are foreseeable. And how do we look at broad-based drug strategies, broad-based vaccine strategies? And much as we've done very well, I commend the government on Operation Warp Speed, because they said, if we're going to get to a vaccine, we're going to have to pick a few potential winners, put a lot of money behind them, know that we're going to throw a bunch of vaccine in the trash, probably for one or more of these things at some point. But it's the only way to get it out there quickly, and then invest in production and distribution and everything simultaneously. We need to be thinking that way, which is, an ounce of prevention kind of, is a pound of cure kind of thing on the front end. So we're going to have to take a step back and really look at that infrastructure, look at that decision making. And that needs to be a worldwide effort, because these illnesses could come from the US, but as we've seen, we're probably not the hottest spot out there when you look at where they're coming from. We've seen Middle East, we've seen China, you see Africa, you see many other countries where, because of the animal species that are there, or whatever the reasons are, we've seen these diseases jump. Imagine if an Ebola mutated and jumped and was, a very different kind of infectiousness to where you didn't identify everybody. Remember the AIDS pandemic? We still obviously are dealing with HIV. It's just a very different disease, but that jumped from animals into man as well. And so we know this happens, and we need to get out ahead of it.
So Bridget asked a question that I think on so many people's minds: schools, education. It's so important. My granddaughter started her kindergarten, first day of kindergarten, sitting behind a computer and waving like this at a teacher, along with their classmates someplace else. That's really not the way we all started kindergarten so many years ago. But it's a very serious issue, right? Because not only is it about the children, it's about the institutions and the communities in which those institutions exist. I was at a Rice board meeting today, as I mentioned earlier, and they've seemed to have been very successful in keeping the number of cases down. They're testing actively, they're doing that. But we've also heard at certain universities, particularly where there have been parties, that things have grown out of control. What should we doing? What should we be thinking about doing about our education system at all levels?
Well, let me start with kids in the schools up to 18 before I get to the colleges and universities. First off, I'll start with the American Academy of Pediatrics. They have very clearly stated, and they put this policy statement out, I don't know, a good 8 weeks ago or so, that all policy decisions, all policymakers, governmental officials should work with an eye towards getting children back to in-person learning as soon as possible. They do that because of the benefits of in-person learning and the detriments we know of digital learning. And those detriments are tough. Actually, the younger kids, it's tougher than the older kids because, and it's tough on families and working families as well, because, you can't just plunk your 5-year-old in front of a TV screen, whereas my 14-year-old, or a computer screen can be on her own, to do those kinds of things. But it's also very difficult and a very unleveling issue from a socioeconomic status for our country as well. So the people who are most socioeconomically vulnerable and the most vulnerable to, suffering from not being in school, are having that very thing happen. So I start with that. Now they say, of course, when it's safe. So you mentioned the right thing, which is, well, there's a whole community that serves that school, and then there's a whole community in which that school resides. So a month ago, what I was saying to people is AAP says this, I'm all for them, but it's way too soon in Houston. We still have these whopping numbers. If you talk to me today, I'm saying, now's about the right timing that we're easing in, and different schools are doing different things. And I would have done things differently and done it on a more organized across the board basis. But we seem to have kind of lucked into probably a not bad situation, which is some of the smaller school districts around town, certainly some of the private schools, are just easing in now. There's been a couple that have been back for a couple of weeks, but most of them this week are doing some sort of easing back in. Might be a hair soon, but I think it's reasonable to look at. And then the biggies like HISD, which has a couple 100,000 students, it's still 6 weeks out from doing something in person. So I think we're going to see a lot of data come up. But I'm firmly of the mind that in the majority of cases, if we mask, if we social distance, and we are really vigilant doing those, so that's a big must have, and we don't use that as a signal to say everything else is normal, right? So the fact that we went back to school can't be like the fact that we went back to work in May and everybody said, oh, good, that means I'll go do my whole social life. I'll get together. I'll cram into a pool on Memorial Day. So, the out of school parties, all those kinds of things need to be attenuated. And that's exactly what we've seen in the colleges and universities. There's quite a few out there that are doing okay. My son went back to school today. His school's doing okay. The neighboring school is shut down. What do I think is the big difference? It seems to be student behavior for whatever reasons, and out of school partying. No bones about it. It is the social lives outside of the classroom setting and the dorm setting and things that were put there in place. So if we have the self-discipline to do the right things, we can get there. But if we don't, we're going to have a real challenge.
Dr. Boom, we've run out of time. I can't believe it. It's 8:31 and we're still going on. And I've got so many questions still from our audience, but we promise everybody to end after an hour. Thank you so much for what you do for us at the Asia Society Texas Center, but more importantly, thank you for what you're doing for our community and more broadly. The work that you and all your colleagues at Methodist and other hospitals in our community keep us safe every day. And we appreciate that work, and we appreciate the work of all the staff that are part of those organizations. So thank you so much. And thank you once again for returning. This is your third time you've been with us. And by the way, I guarantee you it's not going to be your last. So thank you so much for joining us.
Thank you.
For our audience, we want to thank you once again for joining us this evening. As Selena mentioned earlier, the Asia Society Texas Center offers 150 public programs each year featuring arts, culture, education, current events, business and policy, just like this. In fact, the Business and Policy Committee has had 17 different webcasts like this one over the course of 2020. So we're very proud of the work we do, but we also have an infrastructure that we need to support. So once again, I ask, if you're able to, if you're willing, and you've enjoyed this program, we hope you will consider adding your support to the Asia Society by texting Asia Society TX to 243-725 to donate. We hope you will participate. Next week, please tune in on Thursday, September 17th at 7:30. We're going to have a discussion with Dr. Jun Pak. She is the South Korean Foundation Chair at Brookings Institute and the author of Becoming Kim Jong-un, a former CIA officer's insights into North Korea's enigmatic young dictator. She will discuss her book and how Kim Jong-un personality and motivations shape his country's policies and the implications for U.S. and global security. That should be a very interesting program. Check the Asia Society Texas website for other programs. We have many interesting programs coming up in the fall as we get ramped up for the rest of this year. Once again, Dr. Boom, thank you for joining us. Thank you, audience, for joining us. And we hope you all have a delightful evening. Thank you.